All right, this is our final lecture of the semester. I may have said that for the last lecture. I apologize. Getting ahead of myself, I guess. So this lecture is just going to cover a few separate issues: urinary incontinence, dysphagia, malnutrition, and pressure ulcers. These are things that can impact all older adults, and we need to be aware of them and also kind of keep our eye out for them. So first of all, we're going to talk about urinary incontinence. Urinary incontinence, or UI, is when an individual leaks urine when they don't want to. There are basically four types, but you can also have a combination of two or more types that make your diagnosis a little more complicated. Stress incontinence is due to increased abdominal pressure because there's weak pelvic floor muscles. So if someone sneezes or coughs or laughs and have a little bit of urinary leakage, that is when that would occur. Urge incontinence is due to an involuntary contraction of the bladder muscles, and those bladder muscles spasm or contract, and then there's some leakage during that time frame. And then overflow incontinence is due to a blockage of the urethra, and the urine eventually is going to come out whether you want it to or not. And then we can also have neurogenic incontinence. That's due to an impaired functioning of the nervous system, like multiple sclerosis. So like I mentioned, urinary incontinence is the leaking of urine. It's more common in women, than it is in men, and obesity and smoking are risk factors. Oftentimes we'll see that it happens during stress events, intra-abdominal pressure, like I mentioned. The reason it happens more commonly in women is because of pregnancy, especially vaginal births, that disrupts the musculature of that pelvic floor. And then certain conditions like multiple sclerosis or Parkinson's disease that impedes the ability of an individual to control their bladder well can also be a reason. So if we're going to talk about how we treat these, then we need to think about first what the reason is for the incontinence, and then what we might be able to do to assist with that. So stress incontinence, we use a lot of Kegel exercises and pelvic floor exercises. They help strengthen the urinary sphincter and pelvic floor muscles to help control urination. We can also do some bladder training to delay the event so that we can control urge, and the patient will learn over time to delay urination even when there's an urge to do so. Double voiding means a person goes in and voids, then waits for a few minutes, and then tries to void again. A toilet timetable is when we schedule a person. For the bathroom, it's set at specific times during the day, for example, every 2 hours, and that oftentimes also helps regain control. Medications can also be used, but I'll tell you that they'll try the other factors first. So they can use anticholinergics to calm overactive bladders. Topical estrogen can also help. That is a lotion or a cream. They put that in the vaginal area. That helps the tissue in the urethra and vaginal areas be a little more tight. And then we also have a medication called imiprane or tofranil, and that's a tricyclic antidepressant. Some types of medical devices, we have things like urethra inserts, and that you insert before activity and then take it out. When you're going to void, it goes in the urethra or the vagina, depending on the type. A pessary is a rigid ring that's inserted in the vagina, and it's worn all day. It helps hold the bladder up and prevent leakage. We can use some radiofrequency therapy. We use a type of a heat that helps with that, and then it results in a more firm musculature. Sometimes they'll use a Botox. That can also help with overactive bladder. A bulking agent that they might inject around the urethra to help keep their urethra closed. And then sometimes they'll use this nerve stimulator that connects to the nerve that runs to the spinal cord that helps control the bladder, and it emits an electric pulse that stimulates the nerve, which helps with bladder control. We could also do some surgery if other therapies don't work. Sling procedures is a mesh that goes under the neck of the bladder to help support the urethra, to help also stop the urine from leaking out. Colposuspension lifts the bladder neck, and we can create an artificial sphincter. We might use a urinary catheter. Remember, that means we have to change the catheter and the bag every 30 days. There's always a chance for infection. A lot of risks for that. So it's a last-ditch effort. And certainly these days in long-term care, we're highly discouraged to put a urinary catheter in place. And then there's all kinds of different types of absorbent pads we might use as well. So dysphagia is a medical term that's used to describe difficulty swallowing, and it could include starting a swallow or the sensation of food being stuck. Either of those is considered dysphagia. You also need to distinguish dysphagia from odonophagia, which is defined as pain during swallowing, and that could be from infection, inflammation. We might also need to distinguish dysphagia from globus sensation, and this is when there's a constant sensation of something stuck in the back of the throat. So dysphagia is really a symptom that occurs only when someone's trying to swallow. The globus can sometimes be seen in acid reflux disease, but usually it's due to just an increased sensitivity. So there are a couple types of dysphagia. One is oropharyngeal dysphagia, and that's when those neuromuscular processes are not working well. The nerves and the muscles in the back of the mouth or throat. So after a person has had a stroke, it can impact those cranial nerves, which can cause oropharyngeal dysphagia. We could also have some structural causes, but it's a lot less common, like tumors growing in the back of the throat or a narrowed area. Esophageal dysphagia is a structural cause that's really more frequent. It's a narrowing of the esophagus from scarring due to acid reflux disease or inflammation, tumors, compression, those types of things. What we typically see when we have a patient or resident with dysphagia is coughing when they're eating or drinking, choking when they're eating or drinking, and then worst case is an aspiration pneumonia. If our resident aspirates, then they'll end up with a pneumonia on one side. Typically, it usually only goes to one side unless it's really severe, and that can be difficult to treat, but can be helpful as well to know at least we can adjust and help the person learn how to swallow in a safer way. So when we diagnose dysphagia, we use an upper GI endoscopy or a swallow study. Oh, heck. There we go. So barium is the typical medication we use during a swallow study. Hopefully this speeds up here in a second. Let's see. This is going to show you a person who's swallowing, and the food should just move continuously downward towards the stomach, and you can see that white stuff kind of moving down. It's going towards the stomach. It's going towards the stomach. There's a few brief moments where it goes backwards, and that flow looks like it's moving backwards in this video. And then the barium goes to the stomach all the way. That's a typical successful swallow without any impairment. If the barium goes in the wrong direction, you'll actually see it enter the bronchi of the lungs instead of going straight down through the esophagus. Treatment for dysphagia really depends on the cause. And we can use some techniques like thickened liquids or stretching of the esophagus if it's a narrowing, or occupational therapy. That can also help. Swallowing exercises are important because we want to make sure that the person can safely swallow whenever possible.
Stick out the tip of your tongue and hold it between your teeth or lips. Now try to swallow your spit with your tongue in that position. Remember, if your mouth feels dry, swish water or baking soda solution around in your mouth and spit it out afterwards. Let's try that one again. Stick out the tip of your tongue and hold it between your teeth. Now, try to swallow your spit with your tongue in that position.
So this is just one strengthening exercise that physical therapists use. They also will do some other techniques like tucking your chin when you swallow. That's the best technique for someone who has trouble swallowing their medications. It doesn't feel natural. Most people tip their head back, but if you tip your chin towards your chest, you close your airway, and so it leaves the esophagus open, and it gives you less risk of swallowing, aspirating into your lung fields that way. So malnutrition also occurs frequently in older adults, really more frail older adults. Malnutrition occurs for several reasons. Most of those are physiological changes that are occurring in older adult systems that we've already talked about. So we know that our older adults have a loss of muscle tissue and an increase in body fat. Even if their weight's stable, they still have these changes. They experience dehydration because they have a reduction in total body water. Their teeth are often not their own, and that can cause difficulties with chewing as well. Lots of sensory changes that can impact dietary intake, altered taste, smell, and vision. I could tell you when I had my cochlear implant that I had a change in taste for quite a few months. And so all of a sudden one day I realized that I'm putting hot sauce on everything. And I'm like, well, that's because I know I have this spot. I had about a spot the size of a quarter near the front of my tongue that I couldn't taste anything. And I figured out why I was doing it, but I thought it was odd at the time that I kept dumping hot sauce on everything. And then metabolism and absorption of nutrients like iron and vitamins A, D, and B12 are altered. Remember the B12 slide we did early in the semester, which had about 12 different places where vitamin B12 metabolism and absorption was altered. There's also economic and social issues that can impact malnutrition, so income, transportation. So they can't carry as much food especially if they don't have their own vehicle and aren't driving anymore. They also may not purchase as many fresh fruits and vegetables. They might instead purchase things like box cereal or snacks, which are a little easier to carry. And then social isolation is also pretty common in older adults, especially those that have inadequate transportation. And meals are a source of social time. So if you're more isolated, you might not even think about it as much. And then finally, pressure ulcers. Remember that pressure ulcers are those localized injuries. They happen because of unrelieved pressure. They occur over those bony prominences. I would encourage you, anyone who's in a wheelchair needs checked frequently for pressure, redness, and sores. If you have a patient who ends up on bed rest, they need to be checked daily. They need their heels off the bed. They need to be turned every 2 hours. Those are really important interventions that can help. Also, call in a different company so we can get a different air mattress in and help relieve pressure from the mattress itself. We know that there are both intrinsic and extrinsic factors for pressure ulcer formation. Immobility, sliding and shearing forces, moisture on the skin, but also that decreased sensation in our skin and tissues and malnutrition. So our best number one way to prevent pressure ulcers is to prevent them. So use as many different devices as you can in immobile patients. Clean and debride ulcers, except for stable heel ulcers, until you can see that granulation tissue. Use dressings that maintain that good moist wound environment, and select dressings that are appropriate. Then really work on a good fluid, calorie, and protein intake so that they can heal well. Here's just a table with some of the top dressings and which stage of pressure ulcer those dressings are recommended for. Remember that skin tears are a pretty common injury, and that transparent film is one of the very best dressings we can put on skin tears. So keep that all in mind. Make sure that you use the appropriate dressing and that we are changing it frequently and assessing frequently. And then always suspect deep tissue injury. If there's any type of a purple or maroon colored area, if there's a blood-filled blister, and you can see more information about staging at this website. That's the last lecture of the semester. Enjoy!